Good morning and welcome to this webinar on Pectineo-femoral pinch syndrome, or PFPS for short. PFPS is a virtually unheard of, a problem that's virtually unheard of. And to the best of my knowledge, and please correct me if I'm wrong, if you have knowledge of otherwise, I don't think I have ever seen anyone else talk about this. PFPS is a problem that I believe I detected back in 2016 or 2017, and I will tell you a short story about that in a minute. And PFPS is really a problem that can cause anything from mild weakness or mild pain in the groin, anterior labia, anterior testicle, lateral femoral cutaneous nerve, or the abdominal flanks, anything between mild and very, very severe. And it is really a nerve compressive disorder that happens positionally. So the Pectineo pinch syndrome, or the Pectineo-femoral pinch syndrome, involves the femoral, lateral femoral cutaneous, ilioinguinal, and genitofemoral nerves getting pinched by the pectineal muscle, adductor brevis, and adductor longus as you go into hip flexion. You see, although it is not evident from looking at the slide here, or from looking at, let's see if I can get this laser, hopefully that works, the laser pen. Hopefully you can see what I see. Although it is not obvious from looking at just an anatomical drawing, we have to consider the anatomy and the changes in position of the anatomy when the body changes position. Because I was having patients who developed severe groin, leg, and abdominal flank pain, and also anterior genital pain after squatting in the gym, and had to stop that completely. And I realized that this had to be some kind of femoral nerve problem, or at least something related to the nerves in that inguinal canal, but I could not fathom why this would happen. Why would that happen? What could possibly pinch these structures here? In general, now we're going to get back to the story about that, but what I found was that as you go into hip flexion, this took me probably, I don't know guys, 6 months at least, maybe a year to figure this out, but as you go into hip flexion, certain degrees of hip flexion, if the pectineus and upper adductors are very tight, the reason that they're tight is usually either due to hip impingement, hip osteoarthritis, or it can also be stress related. Why? Because of groin clenching. Groin clenching, all right. Extremely, no matter what the cause, extreme groin tightness, when you go into hip flexion, the muscles can be so tight that they lift the nerves that pass through the inguinal canal and squish them towards the inguinal ligament here. And that can cause, like I said, anything from mild to very vicious symptoms. One of the things that's common here is quadriceps weakness. Quadriceps weakness, guys, is generally considered, if a patient comes in with quadriceps weakness, the first guess would usually be spine or something like MS, multiple sclerosis. So the patient might come in limping. You find paresis or at least significant weakness of the quadriceps. They will do an autoimmune workup, a neuropathic workup, a systemic neuropathies. They will do a spine MRI, and maybe even a full spine, and often usually find nothing. Now remember, to get quadriceps weakness, that's an L4 myotome. So to get L4 myotomal weakness from a spine issue, it has to be an L3-4 level brutal hernia to cause that. All right, because the quadriceps is usually very strong, and you need a brutal hernia to cause significant weakness there. If these workups come back negative, no MS, no hernia, and the patient has obvious weakness of the leg, most clinicians will be confounded by that, or Is that the right term? You will be confused by that. Now, what I found is that the compression of the femoral nerve as you go into flexion is what typically causes this issue. And there are clinical tests that we can do for this that I will demonstrate from, I will adhere as a snip from one of my seminars here, demonstrating this on my girlfriend. And you will see that I test her quadriceps. It's not super weak, but it's not good either. And then I put her into hip flexion, and there she has nothing. There is just nothing afterwards. And the reason for that is PFPS. So quadriceps weakness affecting the femoral nerve, very common. You can get femoral nerve pain. So that is pain down the front of the leg, pain down the inside of the leg and calf through the saphenous nerve. That's very common. It can also affect the lateral femoral cutaneous nerve and cause meralgia, paresthetica. There's a lot of confusion that this is a mere entrapment disorder of the skin nerve here at the top of the inguinal canal. I've not found this to be true. I've found it to be usually caused by PFPS. It can also be caused by LPES, which I will cover in another webinar. The genitofemoral nerve and ilioinguinal nerves causes groin pain, can cause anterior testicular pain, anterior labial pain, very common, guys. So pain in the genital testicles after squatting down, after sitting, leaning forward, very common when dealing with this. And it can also affect the obturator nerve. And that is usually caused by severe tightness of the adductor longus. And that can result in medial thigh pain, just like with the saphenous nerve. And weakness of the adductor group as well, okay? So when dealing with adductor or quadriceps weakness, and there's no evidence of systemic neuropathies like MS, and there's no spine, there's no obvious spine problems, you should consider PFPS as a possible cause of that. Now, like I said, the most common cause of this will be for athletes and people who do a lot of sports, hip impingement, very common. If you see this in a young patient who is very active, hip impingement is the most common cause. Do hip impingement workups and look for that. In patients who has developed this later in life, especially after first being diagnosed with hip osteoarthritis, it is usually tightening of the groin due to the joint instability. In cases like that, it's better to do hip replacement because it's very often not treatable. But if it's hip impingement related, you can sometimes, it's not always treatable, but you can usually get pretty decent results. And well, we will get back to that, but the main treatment here is avoidance of hip flexion. You have to find out what degree of hip flexion you can tolerate and avoid that. We're going to get back to that. Now, another common cause of this, although the patient might not have hip impingement, OA, or anything like that, is simply stress. Now, how can stress cause this? Well, it's because some people, when they're stressed, they clench their jaw and they get jaw problems. Other people clench their glutes and their abs and they get back problems. And then there's some people who clench, well, glute clenching can cause hip problems as well, but groin clenching is pretty common in patients who have stress. I've seen this develop after rape. I've seen this develop after delivering a stillborn. It can also happen simply due to stress in general. Some people have different habits when they stress. Let me tell you a story of a patient of mine. This is really where I discovered this issue. This must be 2016. The patient was having brutal symptoms of abdominal flank, anterior labia, all of the things I've just mentioned, guys. Medial thigh pain all the way down to the shin, so through the saphenous nerve. Brutal meralgia, paresthetica symptoms, lateral thigh pain. Brutal. We did a low back MRI, was completely normal. Head MRI was normal. There was no blood work suggesting any autoimmune disorders. And were all of those workups really necessary? Well, in retrospect, not really, because her trigger was mechanical. And if the trigger is mechanical, there's probably a mechanical cause, so either spine or something else. Now, we went back and forth on this for a long time, and I remember there was one day where the patient had taken the tram back home and she could barely stand, and she was in tremendous she told me this was a very tough patient, and she told me she had a 10 out of 10 in pain. She was crawling out of the tram, and we had a longer session that day, and we tried to find the cause because we still didn't know the trigger. And remember, guys, the trigger is very important, because if you understand the trigger, that will tell you something about the mechanism of instigation. That's very important. Now, after a lot of back and forth, we found that if we arched her back more, she would get, it happened during hip flexion. And we found that if I had her adduct, so collect her legs more, it would be less painful. If I had her abduct more, it would hurt more. If I had her flex her back, so round her lower back, it would hurt less. And if I had her arch her lower back, it would hurt more. And what I found was that, well, what is the common denominator here? Arching a low back pre-tenses the adductors, the groin, when you flex your hips. And obviously the same will abduction will also do that. It will pre-tense the adductors. And I had several hours after this looking at the anatomical drawings, and I figured this it has to be a positional change of the anatomy. There has to be some kind of impingement of the femoral nerve and the structures of the inguinal canal as the patient goes into hip flexion. And sure enough, that is absolutely what this is. It is a positional compressive disorder of the nerves of the inguinal canal as well as the obturator nerve. So what we did with this patient, well, I told her normally I like to have the patient arch their backs a little bit when they squat, because it engages the low back muscles and obviously makes it much more tolerant to loads. But if you have this issue and especially if you have no low back problems, then you should round your back a little bit in the bottom. I'm not going to get into the detail of that because it's not the main point of this webinar, but in brevity, as the patient bends, how can we improve their capacity to bending and relieve their symptoms? Because if you can barely bend, how are you going to live your life? Well, you can try to bend without having a very wide stance. You can bend and round your lower back. Yes, it's not great for your lower back, but you win some and you lose some. It's a compromise. Those are some, and obviously you need to find out approximately what degree of hip flexion you can tolerate, because that depends on the tightness and the actual individual tightness of the groin muscles. And avoid going into that degree of hip flexion. And if you do, then you get in and you get out. You get out fast. You don't stay there. So for example, for a patient who has this, sitting on their desk leaning forward, bad idea. Squatting very deep, bad idea. Lunges, bad idea. All right, really bad idea. So for patients like this, they should be sitting on in their chair leaning back. They should be running their back when they squat down, and if they squat down, get in and get out really fast. As I said, you don't want to stay in the position. You don't want to do ass to grass squatting. That's a really, really bad idea for these patients. Now, I used to believe that all tight muscles were weak muscles. And this is usually true, guys. This is usually true. Most of the time, if you have a really tight muscle, it's because it's weak. But there are some caveats. And especially if the muscle is compensating. Now, the muscle will be compensating either for stress, so the patient is clenching to kind of stimulate the stress issue, or the muscle is clenched to compensate for some kind of joint instability problem. In cases like this, the muscle itself will usually not be very painful to palpate, but it will be very hypertoned when you palpate it, and they can handle strengthening of the muscle. The muscle will be strong. It will not be weak. Whereas a weak and tight muscle, which is the most common variant, it's painful when you palpate it, and you strengthen it and you find that it's weak, and it causes post-exercise inflammation. Whereas in an actually hypertrophic and compensating muscle, like I said, it's not so common, but in an actual muscle like that, you can train it and you get no post-exercise inflammation because it's already very strong, it has a good work capacity. Now, I used to believe that strengthening was the solution to all of these things. And like I said, it usually is, but not always. And I actually have this issue myself. I had left-sided hip impingement. I was treating that pectineus muscle for probably 2 or 3 years. And of course, rounding my low back, avoiding full hip flexion, etc. And the problem is that when you do 80% right, if you do the important things right and you do the lesser important things wrong, it's not so easy to find out that you're on the wrong path. So it took me a good 2-3 years to realize that, okay, this muscle is stronger than ever and my hip flexion is worse than ever. So at that point, I decided that, okay, it has to be a compensation for some kind of hip issue. And of course, it was due to the hip impingement. But it took me years to figure all of these puzzles out. So let's talk about the treatment then. Avoiding the position, very important. If you go into the position, you get in and you get out fast, don't stay there. And then narrow stance and round your back as you bend. That's important if you have this, especially if you have it to a severe extent. With regards to physical therapy for this, you need to treat the underlying cause. If the underlying cause is bad hip arthritis, you need hip replacement. You're not going to be able to treat that. If it's mild to moderate, especially mild hip impingement, you treat that by treating the hip rotator cuff. What is the hip rotator cuff? Well, typically people would say the deep 6 lateral rotators. That's true, partially true. What I've found is that we should consider the iliopsoas, a hip rotator cuff muscle, important anterior segment of the hip rotator cuff. The gluteus minimus especially, but the medius as well. Maybe even the TFL, but especially the gluteus medius. It's the most important stabilizer when you go into abduction. And when it's weak, it causes abductile impingement of the hip. The lateral rotators, when they're weak, they cause posterior hip impingement. So piriformis and deep 6, especially the upper portion of the deep 6. So the gemellus superior, the obturator internus, and the piriformis, they need to be strong. The quadratus femoris, it's more of an adductor really than a hip rotator cuff muscle. So exercises such as the what's that called? The clamshell, not found that to be very effective. I found that to often be counterproductive. It causes too much stimulus of the quadratus femoris. So you strengthen the iliopsoas, strengthen the gluteus minimus, and the medius, you strengthen the piriformis, the upper part of the lateral rotators. And the piriformis exercise that you can see here on my channel will get all of those important muscles. Okay, you can just do that. And then you're not going to strengthen the pectineus, you're going to stretch it. And you can find a video for that here on my channel. Now, what about diagnosis? Like I said, the first step here is clinical suspicion. If the patient comes in with nerve-like pain, it doesn't have to be shooting per se because it's not always that simple, but diffuse groin, upper, abdominal flank pain, especially after hip flexion. So pain after hip flexion in the groin or leg or abdominal flank or testicles or anterior labia, that should increase your suspicion or prompt your suspicion that this might be PFPS. How do you go about diagnosing it? Well, you need to exclude spine problems. And if you're not sure, you might even want to exclude autoimmune processes. Do a hip impingement test. If you don't know how to do that, you can simply Google that, but it's fairly straightforward. Do the hip impingement test, check for anterior, abductile, and posterior hip impingement. And if there's very poor movement of the hips, extremely poor movement, there might be OA developing. So you might have to consider that. But if there's not, and if there's decent movement of the hips, you can move on and you can check the pectineus, palpate that adductor longus, the adductor brevis and the pectineus, and you will find that it's very, very toned, very thick. And as you put the patient into abduction and you palpate the muscle, you will feel that they get very, very tense, very fast. There's poor movement, and they will very often have limited range of abduction. Okay. The clinical bullet here, the golden confirmation, is really the hip flexion test, and I will demonstrate that in a video that comes up here. I will just adhere that to this segment. But it is what I do. I put the patient in. I put them in a wide stance. I have them arch their low back, and I have them squat down against the wall, because that will put you in a terrible position, which you got if you have PFPS. Terrible position. Well, let's not get ahead of ourselves. Before I do that, I always do the nerve exam. So I check the strength. If we're going to be specific for this video, I check the strength of the quadriceps and the adductors. Grade 5, there we go. Grade 5, normal. Grade 4, definitive weakness, but they still have some strength. They still have some decent strength. Grade 3 guys, paresis. You have nothing. And you could also use 4+, 4-, 3+, etc. But generally, if they have nothing, that's paresis. If they have some strength, but you're able to break them, that's a grade 4 weakness, and that's what you're looking for. You test them before and after. So I test this patient's strength. Usually, you should make sure that they don't sit in a provocative position, obviously, before you test them. So as you're doing the Q&A with the patient as they come into your clinic, have them sit down and lean back if you suspect this, or if you develop suspicion during the consultation, have them sit back and relax, and then so that you get a pristine test. All right, lie them on the table. You test the quadriceps, you test the adductors, and look at the strength level. Then put them in the provocative position, as I said, and you get them and you have them sit there for about a minute, guys. All right, and you lie them right back on the bed. They have to be quickly back on the bed, and you recheck the quads and the obturators. And now there should be a very clear difference in strength if they actually have this. There should be obvious strength change. And what you can do after that, it depends on how sick they are, because if they're really sick, you might not get such a rapid recovery. But if they're not that sick, you can have them sit down again, lean back, and retest them in 5 to 10 minutes, and you will see that they have recuperated all or some of their strength. And there you go. That's a diagnostic process for PFPS, and the symptoms and the treatment approach for this. So I hope this webinar was helpful. It's certainly a very interesting problem. It's very common. This is not rare. This is common, more than anything affecting women, especially middle-aged women. But it can affect anyone. Okay. And you're really looking for that. Like I said, you're looking for complaints of leg, especially pain, but also weakness of the groin anterior flank of the abdomen, or lateral side of the leg. Like I said, lateral femoral cutaneous nerve, testicular pain after squatting, very common. Anterior labial pain after squatting, very common. Those are the main things that you're looking for. Any of the nerves that pass through that inguinal canal or relate to that inguinal canal can become affected by PFPS.
All right. No, I don't think I'm going to repeat that. I'm going to show you PFPS. In PFPS, you're going to go in and palpate the groin. And I can tell you right now, the groin here is rock fucking solid, guys. She's clenching her groin, 100% sure. And you can see she doesn't like me doing that. It's easier. I don't know. I guess I can do it like this as well. It's not as bad on this side. When you palpate the pectineus, guys, this kind of goes without saying, but especially for those of you both have a lot of experience palpating. But let's say a personal trainer buys this seminar, and they're going to be poking up around here. Make sure to tell, if it's a female, make sure to tell them, look, this is kind of intimate. Are you comfortable with me doing this? If they say no, then stay the fuck away, obviously. If they say yes, they're comfortable with it, go in, but make sure it hurts. Make sure it hurts. If it hurts, there's absolutely no way of misunderstanding that. We have one thing missing here, and that's the PFPS test. All right. So we're gonna do the flexion. So what I'm gonna do first, I'm gonna check the muscle strength. Now for PFPS, which muscles would that be?
The quads, right?
The quads. We will also most likely, in this case, guys, we will most likely also see obturator weakness. The obturator weakness that she has is almost definitively caused by PFPS. And like I already told you, when she likes to sit in the living room, she likes to sit on the floor and eat on the living room. And oftentimes when she gets up, she's like limping after that. So I expect now, we will see though, but I'm expecting that we will see quad weakness on both sides and possibly also obturator weakness on both sides. Let me check, but this is the bad quad, right? But let's get an impression here. Deten, hágalo. She's weak. This is not, because she's a pretty tough lady, all right? She's strong. So this is not normal. This would be normal if I was using that amount of force and the kid was like 5 years old, maybe. But this is not normal for her. That's definitely a grade 4 weakness. You might even argue that that's a grade 4 to 4 minus. I should be using a lot more force to break that quadriceps, guys, unless she has. Y eso no dolió, ¿cierto? No, there was no pain. There was no breakaway pain. Because if, let's say she said, oh, but yeah, my knee hurts. That would be something else, right? Let's check the other one. Empuja. I break. It's stronger on the right side, but I'm still breaking her pretty easily. Siente débil, ¿cierto? So what we're going to do now, guys, is we're going to do the PFPS test, which is basically I'm going to have her sit towards the wall. You can even do it here so you see it better. I'm going to have her feet kind of here, arch your back, sit all the way down as far as you can, stay there for 1 minute. I think for her, because she's already weak, 1 minute will be enough. For some patients, you might do couple of minutes, all right? Amor, ven por acá, por favor. Y que vamos a hacer es que te vas a doblar. I'm just explaining to her, kind of obvious. Vas a doblarte como una sentadilla, la más profunda que puedes. Más abajo. Y sostenerte así. So she's having a pretty wide stance right now. She's squatting pretty wide. That's good because it stretches the adductors even more. ¿Duele? ¿Dónde? It hurts. ¿Dónde? No entiendo. Sí. It hurts. So she's already ready to get up. I'm going to help her up. Okay. Intenta caminar. And you can see she's limp. It's not right. Boca arriba. Rápido. So let's test her now. Let's see if it's worse. And it's already, most likely already going to be worse. Empuja por arriba. Duro. She has nothing, guys. She has nothing. Empuja. Duro. And you see, it's lagging. Empuja. She has nothing, guys. You see that? She has nothing. Let's check the adductors. Por dentro. Deten. She has nothing. Por dentro. This one is not as bad, but it's definitely weak. This was, if I may say so myself, my friends, this was a beautiful demonstration of PFPS. I think it's the first time I've been able to demonstrate this problem so clearly, which is kind of awesome because very helpful for you and very helpful for anyone who will see this online seminar. Questions, guys. First and foremost.
When palpating the inguinal ligament, there was nerves that are more lateral and some were more medial. And is it when you're helping the inguinal ligament, should you just go all the way down? Not all the way down, but like take your time going through to just, okay.
So that's a good question. I normally don't do that. I usually just go to the middle, push and see if it hurts or not. Now, what if I have a lot of suspicion that there might be something there? Well, let's say I'm interested in trying to trigger a tinal sign. If I'm trying to trigger a tinal sign, I need to be on the right nerve, right? So you can say like kind of femoral in the middle, and then more medially towards the pubic bone, you're going to have the ilioinguinal and genitofemoral nerves, and all the way up laterally, superior laterally, that's where you're going to have the lateral femoral cutaneous nerve. So obviously, if the patient has meralgia, meralgia paresthetica, if they have that, then I might push all the way up there and squeeze in there, and I might even hold it to see if I can get a tinal sign. This isn't something I do so often, guys, because just based on the patient's symptoms and all the rest of the pressure tests and the triggers, I will usually know pretty fast what they're dealing with, especially if you have a low back MRI. But this is something that you can do if the circumstances suggest or warrant that. Sure. But it's not something I would normally do. I would just inguinal ligament, painful or not. If it's not painful, if it's not painful, this is important to remember. If the inguinal ligament is not painful to press on, and the patient has suggestive symptoms, make sure you check the quad and adductor strength. If they're weak, it could be numbness, right? And make sure you check the saphenous nerve distally, because they might just be numb. Don't forget that. So that would be more, it's more, maybe not so, position on the inguinal ligament, although there might be some circumstances where that would be warranted. But I'm more interested in pain, yes or no. And if no, numbness, yes or no. Rather than no being, okay, there's nothing. Because in the beginning, when I started realizing, started looking for this, I used to start at the inguinal ligament. And if there was no pain in the inguinal ligament, I wouldn't even go further down. And then later on, I realized that, oops, that was a big mistake, because they're just numb. And I missed a ton of cases. Make sense?